Hi, everybody. Dr. Magarelli, CNY Colorado. Welcome to our Tuesday evening pearls from the Pacific Coast Reproductive Society. Hello, Jessica Kimmy. Welcome. Hi, folks. I'm going to be doing a lecture, so all you wonderful people on Instagram, jump over to Facebook Live and YouTube, and I'm going to talk about pearls from the Pacific Coast Reproductive Society. This is a meeting I just came back from, and I'm extremely excited about things I want to share with you. Hello, Jessica Kimmy. Everybody who's on Instagram, jump over to Facebook Live and YouTube Live. It's going to be a very short lecture. Some of the things that I learned from my trip to Palm Springs to go to the Pacific Coast Reproductive Society. I happen to love that meeting. I was past president of that society, and God, it was so great to be in touch with people. Hi, Machina. Hello, Tanisha, Felicia. Hello, everybody. So we're going to be talking about some of the things I learned while at that meeting. And then hello from Texas. Hi, guys. Welcome, Sarah Connor Miller. Welcome, Yamil 2006. Welcome, Stephanie. So we're going to be talking about pearls from the Pacific Coast Reproductive Society. So if you're on Instagram, jump over to Facebook Live, YouTube Live. After I go through that, I'm going to answer some questions and answers. Hello from Orlando, Felicia. Welcome, Kim, Celeste from Ohio. Hi, everybody. Hello, Amanda Villa. Hi, good to see you, my dear. So all you guys are on Instagram, jump over to Facebook Live. I just came back from the Pacific Coast Reproductive Society, and gosh, it was a great meeting. And hello from Houston, Making Baby McCree. Welcome back. But jump over to Facebook Live, guys. Who's ever on Instagram, I'm going to do some Q&A after I talk a little bit about some of the new stuff. Love the hat. Yeah, it's I love the hat too. It's just something that I just decided it's me. Alicia, hi, Dr. Mac. Finally have my follow-up tomorrow with you. Finally. Well, good. I'm looking great from San Francisco. Thank you. What's the Facebook page? It's CNY Fertility. That's the Facebook page. You guys know that. Help her out. What's the Facebook page? What's the YouTube page for them to jump over? I think it's just the Facebook page should be CNY Fertility Live, YouTube Live, of course. And then you could stay on Instagram. You'll hear what I have to say. But, you know, most of what I'm going to be showing you now, actually, you can listen to. So if you kind of want to, not jump over, but, sometimes it's better to see the PowerPoint that I do every other time. I always do a PowerPoint every other week as best I can. How you guys over there on the Facebook Live and YouTube Live? So people say hi. Make sure I see this thing ticking because there's been no movement here. So people say hi. The link is Facebook at CNY Fertility Center /videos. So that's where you get over. It's CNY Fertility /videos on Facebook.com. CNY Fertility Videos. You guys know that. Oh, there you go. Hey, Heather. Hi from New Jersey. Okay, Misty Draper, 88. Jump over to Facebook Live. I'm on Instagram. Found it. I'm in so many support groups. Good, Naisha. We really appreciate that. And by the way, we do know that you guys support each other. You're out there to make sure everybody creates that one beautiful baby, and we're all there in this with you. So we know it's a challenge. We're here to help, and let's see. It's been about 5 minutes. So, folks, all you guys on Instagram, if you want, jump over to Facebook Live. I'm going to briefly go over about 5 or 6 or 8 major things that I picked up at the meeting. And then I will jump back to answering questions. Okay, so let's go. So the Pacific Coast Reproductive Society is one of the oldest fertility societies in the United States. It started in California. We now have people from all over the world, but it's mainly focused on education, but in a collegial way. Now, I dress like this through the whole meeting. In other words, it's no ties, relaxed. You sit drinking pina coladas, and so the place is there for us to learn. So let's do some learning here. What did I learn? So the purpose of this brief little talk tonight is to outline in brief form some key teaching concepts that I learned from this meeting. I want to reinforce some of the key CNY protocols that were reinforced at the meeting, which I'm, two beautiful babies. And then I want to elaborate on some areas of future development in the field of reproductive medicine. And I want to reveal some continued controversy. So let's talk about non-invasive PGTA. Now, you're all familiar with invasive PGTA, where we grow the embryo to the size of a blastocyst around 5, 6, or 7 days. At that stage, the embryo itself is hundreds of cells. So we can take 2, 3, 4, 10 cells from the placenta part, not the baby part, of the embryo, freeze the embryo, then send those cells to a genetics lab, and then what they can do is they can detect the chromosomal complement in those cells, and then infer from that the embryo is either normal or abnormal, mosaic, and it can tell you whether they're boys or girls, males or females. Now, for the longest time, probably the past 5 to 8 years, we've been looking at a non-invasive way to do that. Can we do something with the culture media in which the blastocysts are growing? We know that as it grows, it throws off some cells. Can we collect those cells in the media and in some way tell whether or not the embryo is chromosomally normal? Well, we're not there. I'm going to be very brief. We're not there. There are people who are trying to make this work, but it doesn't have the confidence or the precision of PGT the biopsy does. So Dr. Richard Scott, a well-known authority on many things in reproductive endocrinology, he essentially went over the literature, and currently that's not an area where we have reasonably good data to allow us to tell you whether it's normal or not, or whether it's a boy or a girl. So unfortunately, right now it's wait and see. I do think down the road we are going to be doing more non-invasive PGTA, but not right now. Another area, let me change the background on this because it's interfering. Let me get this down here. Jump over down here. I'm just going to change the background on this to something very simple, minimal, maybe that one. Yeah, okay. So this was talking about natural modified or modified natural frozen embryo transfers. So there are 2 types of embryo transfers. Most of the time, we do what's called a medicated frozen embryo transfer. We control everything. What these studies are beginning to suggest is that the corpus luteum may have some potentiating and also protecting factors that we don't include in a medicated cycle, because we're giving just pure progesterone and pure estrogen rather than allowing the body to produce its own progesterone from a corpus luteum. And what they found was in a natural modified FET, they found reductions in hypertension and preeclampsia, which is one of the slight, minimal, rare events associated with frozen embryo transfers. In other words, it's not everybody who gets preeclampsia, not everybody who gets hypertension, but there's a slight increase. And what they found in these natural cycle FETs is that there is a much lower incidence of these sequelae of pregnancy, bad effect. So I would say that for me, in reading this study, and I'm going to pursue it, and I'm actually going to do another talk on modified natural cycles. And there is some suggestion that it helps. Now, what I want you to remember, though, in a modified natural frozen embryo cycle, timing becomes critical. So you can miss cycles if the timing is wrong, whereas under a medicated cycle, we completely control the cycle. So it's a 6 of one, half dozen of the other. If you have a flexible schedule, you may want to do the natural modified. If you have a very strict time frame where you have to have your transfer, and it must be this month or a certain day, because as you know, we don't do transfers on Sunday. So, for example, if the ideal time because of a natural cycle is Sunday, then we just missed that month. So again, pluses and minuses, but something I'm definitely going to continue to look into because I'm fascinated with it. What about progesterone? There's always a discussion on progesterone, the route of administration, how much you should give, and live birth rates. And this was a very nice study looking at the comparing PIO progesterone plus vaginal progesterone, and then just vaginal progesterone. And in all of the studies, the vaginal progesterone is inferior. So folks, I know you don't want to get an intramuscular shot. I know, but the studies continue to this day for the past 35 years show that by doing the progesterone injections, you get a better outcome. In this particular one, they had more live births in the IM progesterone and the IM plus vaginal than in the vaginal alone. And then when it comes to the concentration of progesterone, the IM progesterone seemed to be protective of the level of the progesterone for a good outcome. In other words, if the IM progesterone was less than 10, it really didn't impact the outcome very much. Whereas if the progesterone levels were less than 10 in a vaginal vaginal progesterone treated patients, then their outcomes were lower. And then finally, when they looked at the data, those folks who did vaginal progesterone only showed an increased miscarriage rate. That's what SAB stands for. So these hybrid cycles, these medicated natural hybrid transfers, they may have a place for us, as I mentioned in the previous slide. But again, we need to understand that that progesterone itself is best served when we would provide it intramuscularly, and then we can transition to vaginally. But certainly the first month, I would do progesterone injections. So that was another thing we learned. Now, mosaic embryos, this was fascinating. They found that 15% of all IVF patients have mosaics in their outcomes when they do PGT testing. Mosaic is an embryo that's something normal, something abnormal in the cells. So there's a mixture, and so they're not 100% normal, 100% abnormal. And what they have shown is that there is a huge variation in mosaicism based on the laboratory that you go to. So each IVF center can get from Cooper Genomics their mosaicism index. And I don't think they know exactly why the various labs differ, but it does say, it is something for us to pay attention to. Another good point, which was excellent, is that if you've gotten mosaic embryos in the past, it does not mean you're going to get mosaic embryos in the future. So that was very reassuring. And then finally, if you transfer mosaic embryos, and you can get babies, if you're greater than 42, you have 52% more embryos to transfer. And if you're under 35, you have 33% more embryos to transfer. And if you don't know the game of IVF, it's all about numbers. Number of eggs, number of embryos, number of normal embryos, number of embryos transferred. So that was reassuring to me about our role in transferring mosaics. So that was very reassuring. So they also, I have more I'm going to talk about mosaics in the future because we got a lot more data, but that was very interesting to me. Endometrial receptivity assays, the ERA and the ER-peak. Pretty definitively, there's no advantage to proactively doing an ERA. So folks, if you have embryos, you don't need to, do I have to do a ERA first before I put the embryos in? They don't show that it has any advantage to those who don't do the ERA. Now, this isn't different than in patients where you've tried transferring and you've done euploid transfers and they don't get an implantation and they haven't had a pregnancy, then in those cases, the ERA may point out those few individuals, maybe 1 in 4, maybe 1 in 5, maybe 1 in 7 individuals who would benefit from doing the ERA, which is really a way of us proactively testing a cycle to see whether or not the timing for transfer is 6 days of progesterone or not. And then it comes back with an equation which tells us how many extra days or fewer days to put the progesterone in. So what this is saying to me is save your money right now. It doesn't show that that everybody should do this add-on just because somebody else did it. As a matter of fact, it doesn't show an advantage unless they've had some failures in the past. Okay. This was very cool. A study was done looking at ultra-fast thawing of vitrified embryos. Now, it's a new study. I've got to do a little more homework. But what they've been able to do is decrease the thaw from 14 minutes per embryo to 1 minute. This is a tremendous savings and increase in efficiency in the IVF laboratory. If we have 20 or 25 transfers in a day, it's an enormous amount of time just waiting the 14, 15 minutes for the thaw process to work, go through 5, 6, 7 steps or 3, 4 steps. This is a one step that what was surprising was that the pregnancy rate in the control, which is the 14 minutes, was 67%, but in the ultra-fast thaw was 83%. And the overall implantation rate went from 49% in the control to greater than 63%, which is extraordinarily high in the ultra-fast. So, gosh darn, for sure, as lab director and medical director, I'm going to dive into this. I'm also contacting the author and say, hey, man, we're really interested in pursuing this. So this will be a very, very exciting way for us. Because again, guys, the way we are at CNY are able to provide the service that we do is through efficiency and through reducing our marketing. We don't spend a lot of money on marketing because that money, unfortunately, was added to the patient's cost. So if we can use less tech time on these transfers, then we're just much more efficient. And I'm really, really excited about that. So what are the key CNY things I picked up when I was there? Well, at CNY, we recommend, and I always order IM progesterone, PIO, plus vaginal progesterone. So I'm going to continue to do that. We do support modified natural FET cycles. However, there's one caveat. It's calendar dependent. So if time is critical, not likely the best. We support the transfer of mosaic embryos, and I'll come back with you probably in a week or so, or 2 or 3, just depending on all the things I'm getting done on talks. But there's some really good information on transferring a mosaic, so you should feel comfortable doing that. We provide the ERA. However, we do not recommend it for our primary use. I recommend it if there's a failed frozen embryo transfer or there's a failed fresh transfer. So that is helpful to you because that's, again, another financial savings for you guys. And then currently we do not offer non-invasive PGTA. It's not really commercially available, so it's not really something that we do. All right. So I know that was a whirlwind travel through my time at Pacific Coast. It's not even touched the surface. I also was teaching at Yosan University, which was the university that was started by Dr. Credenda, myself, and a dozen other folks. Had the inspiration over 10 years ago to create a board certification process for acupuncturists. And I taught them about the COVID vaccine and its extraordinarily safety. They talked about nutrition. If there's anything I can say is 8 servings of fish a week, is something that means between the two of you. So 4 servings of fish, seafood is super for fertility. But I'll have a lot more to say about that. Oh gosh, the list goes on, but it has been a real privilege to go and see my fellow reproductive endocrinologists. We're all struggling with trying to get staff. IVF is growing all over the country. We need more doctors. We need more nurses. We need more embryologists. We need more front desk. So it's an amazing growth phase, and at CNY we are constantly looking to expand our offerings. But as you know, I'm kind of that geek who likes to look at the data. So those were the ones that stood out to me. And anyway, so with that, I'm going to open it up to questions. And we can start anywhere. So let's start with Amber, the most recent one. My only issue is my tubes are closed. Okay, it's not a question. Felicia, I'm 36 years old. My AMH is 5. I have PCOS with a high level of testosterone. I keep hearing about priming. What is that, and will I need to prime? Priming is really a process dedicated to folks who have low ovarian reserve, and you do not have low ovarian reserve. Side note, I absolutely love your style. Thank you, Tori. Other questions? Yeah, I'm sorry. I know I missed a lot of questions coming by here. So please, folks, you can stay on Instagram, YouTube, wherever, and just throw out some questions because I'm absolutely happy. Okay, how effective is the Lupron shot when you can't afford the surgery? If you're talking about the treatment of endometriosis, I think there was a recent study saying that medical therapy is not as good as surgical therapy in terms of pregnancy rates. So it doesn't mean you don't try, but that was something recently today. Amber, I always get 11 to 15 eggs, mature and fertilized. Day 3 are all great. Day 5, they drop off. Any guesses? Only problem is my tubes are closed. No, Amber. The problem is the egg-sperm interaction. If you can get to day 3, it's not a sperm issue. If you can't get to day 5, it's likely an egg issue. I don't know much more about you, but there may be an egg issue. It does not mean you can't be successful, but there's an egg issue. It's not a tube issue. I'm 30 years old and I don't know where to begin. What would you suggest? Well, Camilla Isabella, definitely what I would recommend is you get evaluated. Do you have eggs? That's an AMH level. Does your husband or partner have sperm? That's a semen analysis. Is the sperm and egg able to meet? The fallopian tubes open? That's a hysterosalpingogram. Is there a safe place for the baby to grow? That's a uterine evaluation. So hysterosonogram, hysterosalpingogram. So those are all available. I am beginning my cycle tonight. What's the most important thing to do or know going into this? Well, avoid alcohol, tobacco, drugs. Stay away from smokers. Use Zero Vital, which is a vitamin you can pick up at Costco and other places. Zero, SEROVITAL. You're welcome, Camille. Do acupuncture. Follow the directions. Ask questions. Rosanna, what protocol would you suggest for someone who had a positive ANA and a TBG of 36.2? Total, I'm not sure what that means, but you probably have some sort of immune issue. Well, it's not a protocol. It's adding Lovenox and baby aspirin are the best. Kim Mercado, Dr. Mag, you mentioned ERA only after a failed frozen transfer. If I had a failed own eggs, but now doing a much younger donor egg, should I do ERA? Yes, because it has nothing to do with the egg. It has to do with the endometrium. What is the update that azithromycin is now conflicting with other medications? How and why? Don't know the answer to that, Misty. Sorry. What should progesterone be? You want it greater than 10, the progesterone. Ashley, 3 frozen embryo transfers, 1 miscarriage or 2 miscarriages. What else can I do? Acupuncture, Serovital, growth hormone, low carb eating. Yes. Jen Lynn Miller or Wells, 4 fertilized eggs frozen day 3. My embryos are 2-9. I did not do PGT. Which should I transfer? I would leave that to the embryologist. Ask them. Sarah, we just had our consult last week and are excited to see you in May. They recommended trying Zymote membrane. I do not use Zymote. I don't recommend Zymote membrane. Any recommendations for egg quality? Yes. Growth hormone, serovital, acupuncture. Oh, thyroxine binding globulin. Thank you. Well, that means that's anti-thyroid antibodies, I'm assuming. So make sure you're taking, Roxana, make sure you're taking some level of Synthroid or NP thyroid. Allison, 29, PCOS, 3 miscarriages. Currently waiting for a consultation, but considering a fresh transfer. If we get embryos, any genetic testing for the rest? Any thoughts? I know people are doing that, but I just think about it differently. If you're going to do PGT-A testing, and the big expense is the biopsy, and we don't charge by embryo, but they do charge testing by embryo, you probably want to make sure that you test all of the embryos, not some of them, and why risk a miscarriage? So just do the PGT-A. When should I get my HSG or SHG? That's done on day 9, 10, 11 of the menstrual cycle. Should do a saline sonogram early in the cycle and FET later the same cycle? You cannot. Do you recommend PGT testing for age 34, almost 35? The data seems, Angela, that 35 to 40 seem to be the best. How many sessions of acupuncture? Well, there's the Credenda-Magarelli acupuncture protocol, the CMAP protocol, is about 9 or 10. Now, Misty, don't have an answer for you. That's why I'm not answering you, okay? Does freezing on day 3 preserve the longevity of embryos that would otherwise degrade before day 5? Well, again, the goal is to find the embryo that can make a blastocyst and implant. So that's what you have to do. Whether you do it in the laboratory or in your body, that's what you have to do. Missed you so much today during my FET. Dr. Fink doesn't name embryos. Oh, Ashley, you should have said, hey, listen, I want my embryos named. Go get Dr. Magarelli. I don't know if you could have done that. I did human growth hormone and acupuncture and no success. Well, they're not guarantees, Amber. They're just adjuncts to try to figure out what's going on. Martha, I'm 39 with PCOS, Hashimoto's, and my AMH is 7. Is that okay number? That's a great number. I'm taking Omnitrope, but just read that people with cancer should not use it. And I had bone cancer. Do not take it, Martha. Do not take Omnitrope. Can I get an HSG and having an Assure birth control? Absolutely. Amanda, 3 mature eggs, 1 fertilized. Is there anything else to help with fertilization rate outside of priming with Omni, Serovital, low-dose naltrexone, keto, supplements? No male-based on a semen analysis. Well, your AMH says everything, my dear Amanda. That's really what you're dealing with is the low AMH. Are day 3 embryos the same quality as day 5? Never, not at all. They're an unknown quantity in day 3, whether they're going to grow to a blastocyst or not, whereas a day 5, 6 is a blastocyst. So that's where the money is. Felicia, my OB/GYN thinks I have endometriosis. What should I do to know for sure? Surgery. Lauren, are there any signs that contacting COVID for vaccinated individual can affect egg quality, and is it a permanent effect? It does not affect contracting COVID. An infection has a short-term effect, very short-term, but no long-term effects on egg quality or egg availability. Is ovarian PRP usually done on cycle day 21, and can we have more than 1 ovarian PRP? Heard it's better to have done more than once. Yes, you want to do it about 3 times, 1 month separated. And you can pretty much do it anytime during the cycle, honestly. Mariam, I'm 39 with good AMH and FSH. Embryos don't make it past day 3. Do I have any chance of pregnancy? Sure. Put them in at day 3. Tori, I don't have any euploid embryos left. I've had 1 miscarriage, 1 successful FET, 1 failed. Recent failed. Named Gloria, of course. That I did everything immune, etc. We have only 5 low-level mosaic segmented embryos left. Used all euploids, all grades around 5. Absolutely put the mosaics in, because the data seems to show it's much better inside you than in the garbage. Okay, it really does have an increased risk. Is a thickened heterogeneous endometrium difficult for implantation? Yes. I mean, it should be trilaminar and somewhat homogeneous. Well, thickened heterogeneous. If it's trilaminar, then you're okay. I may have misreplied to the other question earlier. So did I. Look up research on oocyte. Also, CoQ10, of course, Heather, growth hormone, serovital. These are all useful acupuncture for improving egg quality. Should endosurgery be done prior to retrieval or prior to transfer? Prior to transfer. Get your eggs, make your embryos. Get your eggs, make your embryos. Is IVF the only option if my husband has poor sperm morphology? It's the best option, not the only. It's the best option because it's of efficiency. It works. Embryo failure of PGTA normals, ERA is normal, no endo. If I could do only one thing to improve chances, what would it be next? Well, do more than one. Do growth hormones, serovital, maybe a PRP wash, HCG wash, acupuncture. What is looked for when determining a 3 versus 5 day fresh transfer? Mainly the number of embryos you have and how old you are. What should your E2 level be at baseline? We might get less than 80. Will doxycycline after FET lower my progesterone? No, it should not. I just turned 31. Fertility issue, no fertility issues. Use donors. Should PGT test my embryos? Not really. It's expensive, and I'm not sure you're going to get much of a benefit. Thanks for the kisses. Let's see. You guys are rocking it here. Great questions. What is serovital? It's a complex of amino acids that can pass into the blood-brain barrier to allow for your own body's growth hormone to saturate your system, which allows for, let's say, regeneration of healthy tissue. Would an ovarian cyst prevent me from starting an IVF cycle? Yes. And queen, you just wait a month and usually it'll go away. How do you treat PCOS? Well, you treat PCOS depending on what your goals are. If it's fertility, you can lower the androgens, certainly a low-carb diet. There are medications that can make you ovulate. There are medications to lower the androgens in your body. Lots and lots of things to do. Yes, Angela, the best place to get serovital is Costco or Walmart. Can a negative 22 aneuploid self-corrective transfer? Nobody knows the answer to that. Glioli. Baby number 3, do endometrial polyps have to be removed before pursuing further fertility treatments? Timed intercourse, IUI, IVF. Yes, they do. My first retrieval was 4 follicles with 1 egg. The 1 egg degenerated. I'm 42 and have a low AMH. Do you think I still have a chance of a more successful retrieval? Well, if you do back-to-back, or you can do dual stim, which is 2 retrievals in 1 month, you may get enough eggs to make enough embryos to make a baby. It's a numbers game. It is absolutely a numbers game. So, and it's a persistence and perseverance game. Then lots of IVF cycles with ovarian cysts worked out okay. Heather believes that ovarian cysts are okay with IVF cycles. I don't. Well, it depends on the size. If it's very small, then it's not going to be a problem. But if it's large, it does reduce the number of eggs that you're going to get. And again, eggs, numbers is everything. This is Stephanie, unknown infertility at 22 eggs, 11 mature, 5 embryos, none group has 3, so nothing to freeze and test. What can I do round 2? Serovital, growth hormone, acupuncture, look at the stimulation, see what else you can do with a doctor. 2 failed transfers, embryo tested normal hysteroscope and DDRA still failed. That's Amber. What can you do to get more, mean sperm counts up? You can try Clomid. You can try HCG. Yeah, you can try gonadotropins. See a urologist. What are you looking for at the first ultrasound after confirmed pregnancy? Make sure that the embryo, the fetus is inside the uterus. We don't want it to be an ectopic. Any success with fresh transfer with 1 closed tubes have nothing to do with it. Now, hydrosalpinx, I would definitely fix it by ligating the hydrosalpinx, because that fluid inside the hydrosalpinx may, quotes, poison the situation. So see if you can get that fixed. What can I do to help with implantation? Acupuncture, serovital, keto approach, low carb eating, growth hormone, PRP washes, HCG washes, low inflammatory diet. Allie, I read XC increases the chances of aneuploid embryos. Not that I know of, and I just reviewed that, so I don't think so. I don't think so. Can you take serovital and omnitrope together? Absolutely. I strongly recommend it. And by the way, the serovital is for the male and the female. Would you recommend surgery to remove an endometrioma prior to retrieval? Yes, because you didn't get any eggs last time. What's a PRP wash? That's a platelet-rich plasma from your wife that's concentrated and then put inside her own uterus. It has growth factors, so it can definitely help. 39 years old, embryo's partially implanted. What can I do to improve any chances of becoming pregnant? I kind of think I've said all the things about acupuncture, serovital, growth hormone, the keto diet, avoiding alcohol, tobacco, drugs. Certainly no smoking on either partner. Valerie, me and my husband will be using a surrogate. We'll be allowed to be in the room for a transfer of GC. I'm doing an egg retrieval in Colorado in June. We plan to do a fresh transfer in June, hopefully with you. We'll definitely be asking to have you for the transfer. Oh, can you and your husband be in the room with the GC when we transfer? Absolutely, as long as the GC permits. What's the difference between the HSG and saline ultrasound? Is the saline ultrasound easier pain-wise? Some people say it is, but the HSG is really good at telling you if your tubes have a problem. Now, if you're doing IVF, then no worries. So platelet-rich plasma is a concentration of blood serum that allows for growth factors that are used in joints and teeth, where we're now using it in fertility to rejuvenate the tissue. What is the difference between duostim and back-to-back cycles? Can you do both duostim and back-to-back? Yes. Duostim is that you want to get 2 retrievals in 30 days. Back-to-back means you do 1 retrieval, you have a short rest, then you do another retrieval. So that takes about 2 months versus duostim takes about 30 days. What are the factors that do not allow a fresh transfer? Elevated progesterones above 1.5, estrogens above 3,000, or something in the uterus, of course. Tori, I did PRP washes 24 hours prior to transfer, but I was bloated for days after the transfer failed. Would you suggest against this next time? I'm not sure where the bloating came from. I'm not sure. I don't think those are related. We are transferring our last embryos at our current clinic, then going to CNY. Have heard great things and seems way more helpful. Okay, thanks, Amber. Believe all beauty. I agree. You're very welcome. Remember, I love kisses, so if you want to send kisses on Instagram, you can always kiss. Frenchie, can I still do a first blood work and ultrasound with a missed menstrual? Yeah, don't get too tied up with bleeding, and also don't get hoodwinked into waiting for periods months at a time. If you don't get a period within 28 days, and that's it. So if you haven't had a period for 28 days, contact the office, go in for a baseline, and you may be able to start a cycle, but there may also be something else going on. How does PRP wash help? It's growth factors and the endometrial. Oh, here comes the kisses. Thank you. It's growth factors. I had PRP in November. Should I do another PRP? Yes. I'd say 3 months in a row, Renee. What are the reasons for the high percentage of immature follicles at egg retrieval, Stefanova? Possibly you could grow the follicles an extra day. Lots of kisses. I'm loving that. Possibly it's a stimulation protocol. So when you go through another protocol, just ask them to be careful about when they trigger you, and that should help. Did you know how long it takes to receive the results from the saliva genetic testing that CNY recommends? No, I don't. Hey, Dr. Mag, one more question. I am set up to do a hysteroscopy, laparoscopy. Do you think I should do the ERA on top of that before transfer? I'm assuming, Kim, you may have had some losses, and I would say yes. Oh, Renee, thank you for all those lovely kisses. Thank you. All righty. Do you know? Okay, we already answered that one. Okay. Really appreciate you guys asking these great questions. And Things are going really well. Paige, lost my period in September 2020, finally got it back in December 2021. We got it with progesterone pills and it did Clomid for a year. It didn't work. Now I am kind of regular with periods. I've been trying for a couple of years to have kids. Should we start infertility treatments? Absolutely. Currently doing IVF 4 follicle sizes. Doctor wants to trigger today, but doesn't recommend gonal 100 units. What do you think? I'm afraid that the 14 to 50 will be too small. Yes, that could be. You can insist to grow one more day, but then you may lose the 19 and 20. Amanda, miss seeing y'all in the office on Thursday for a treatment transfer on Saturday, but just so you know, Dr. Banerjee was fantastic. Thank you so much, Amanda. Dr. Banerjee is such a sweetheart. And he's just an asset. If you're out there, Dr. Banerjee, big shout out for taking care of the patients. We appreciate it. Is Plaquenil twice a day recommended if I've had failed FET with normal embryos? I do not prescribe that. I would leave that to other doctors to do. It's not something in my repertoire, and I haven't seen enough data to convince me one way or the other. My lining is usually perfect or thick. Should I still consider a PRP if finances are tight? No. Renee, having adenomyosis, what can I do to help implantation? I suffer from chemical pregnancies. Well, Renee, some people suggest that you can take 3 months of like a lupron down regulation. That's something you could do. I don't recommend surgery. Does Zymot are now in stock, or do you need to order in advance? I don't know the answer to that. HCG wash and PRP washes can be done the same day. Do they affect the lining the same way? No, very differently. The HCG is dealing with the receptors. The PRP is dealing with growth and basically a rejuvenizing property. All right. Thanks for the kisses, Renee. All righty. All right. Lots of folks joining in. Thank you this is Dr. Magarelli, CNY Fertility, Colorado. Tuesday evenings, 4 to 5 Mountain Time. What is the Prograf used for? People use that for the reducing inflammation and for the immune system. Have you noticed asthmatic patients have more of a challenge with frozen embryo transfers? If so, do you have recommendations for them? No, I have not noticed that property. Can cabergoline affect the eggs during the stims for high prolactin? No, it's very safe. How far are the consultations out as of today? You know, I'm betting it's 3 to 4 months, but please, we get a lot of people for some reason don't answer their phones when we call. So definitely be on the add-on list, cancellation list. Definitely do that. Related to my last question, having follicles 2019-15, I'm triggering today, but I'm wondering if you think they should be a good idea to keep gonal injections for today. Yes, absolutely. Keep your gonal injections for today. Is there a way to prioritize low-level mosaic segmented embryos? No clues how to decide, and if we should do 2 instead of 1. Well, Tori, there's no right answer. There is a lower chance of implantation, a significantly lower chance. So, in circumstances where you're already starting with a lower chance, especially if you've had failures before, then you may want to put 2 in. But again, I wish I had that slide on prioritization. I don't have it in my head. I apologize. Oh, go to the Cooper Genomics website. They may have that, how to prioritize mosaics there. I'm checking on Serovial. Is it an anti-aging one that supports youthful pituitary function? Yes. I use Serovital to stay young and handsome, right? That's what I use it for, and to keep my joints working because I'm an old man. But you're using it to stay young and filled with life. So definitely, that's its purpose. Does a suspected scar tissue pain from excisional lap salpingectomy from 2020 need another resection surgery before FET? Not likely. Or Alyssa concerns me for long-term side effects. I wouldn't be concerned. It's more short-term, and you're not going to be on it very long. My transfer is Friday. I'm so excited. Was able to book acupuncture. Good, last minute at your wife's office, but they don't have availability for me after the transfer. Well, you know what, Jasmine, when you're there, raise that issue again. Hey, I want to get my post. I'm not saying my wife should run her practice, but I know they stretch themselves. So, yeah, I don't know how to connect with you. So, is that how you spell your name in the chart? Jazmin? Is that how you spell it so I can find you in the chart there? Immune protocol for Humira and IVIG is expensive. What is similar if insurance denied it and having a hard time implanting? Not much is similar, but again, I would do maybe PRP, Jasmine Valenzuela. Okay, let me, Jasmine Valenzuela. I will do what I can, Jasmine, as best I can. Cycles that are irregular are usually 36 days or sometimes months at a time. I'm 34. If they send me for an ultrasound and blood work, do they give me meds to start the period, or do they have to go ahead and start the IVF meds? Yeah, they'll give you meds to start your period. A nurse asked on the portal said that they would prescribe meds to start the period. Yes, absolutely. Immune protocol 4 is expensive. What is similar? That's the same question. So, growth hormones, serovital, PRP, acupuncture, low carb eating. Jasmine, my pleasure. Kisses. Love kisses. All right. Voice is going quickly. All right. What do we got going here? Lots of kisses. Can I do a fresh transfer with prolactin level of 30? I would not. I would get it back into the normal range because prolactin, you're welcome, Renee, keeps you from implanting. I mean, when women are breastfeeding, that's a natural contraceptive because of the prolactin levels. So get that under. And by the way, it only takes 4 days to get the prolactin fixed. So get on the meds, call your doc, get on the meds, and 4 days later, your prolactin will be perfect. Bridget, 39, have 3 children, but have had a tubal ligation. I'm doing my first FET with donor eggs. What is the best protocol? There is no best one. It's estrogen plus progesterone. You can add serovital. You can add acupuncture. You can add low-dose naltrexone. You can add Lovenox. You can add aspirin, and that's part of our immune protocol too. But when people talk protocols, to me, it's estrogen plus progesterone. Does the mini retrieval produce better embryos? No. Jasmine, I started vaginal progesterone this morning at 11. Am I supposed to take it twice a day? What time should I take it at night? Don't worry about it. If you're doing it midday, then do it just before you go to bed. Don't get too wiggly about 1 hour, 2 hours. Make it so it's convenient for you. It's okay that you start at 11, maybe before you go to bed at 9 or 10. Well, I go to bed at 9 or 10. You may go to bed later. Bridget, my pleasure. Does a mini retrieval? Oh, I already said that. Okay. Jasmine sends me another kiss. And my heart goes out to you, all of you guys. I truly appreciate you guys. I know this is a tough time in the world and lots of stressors out there. Meditate, go for walks, hold your partners, tell them you love them. What happens if you have the endo surgery before egg retrieval? The doctor at the Atlanta clinic informed me it was better, so I allowed her to do it. That's fine. No, that's fine. I don't know how old you are, Shantia. Yeah, no, that's fine. You could do it before, you could do it after. I just am one of those people who love to put embryos in the bank before I do surgery. That's all. That's just my way of doing stuff. It's my pleasure, Tori. Guys, be there for each other. Talk to your closest friends. Trust that your lives have purpose, and part of the purpose is making one healthy baby. And I know somebody wants 2 healthy babies, but we like you to make one healthy baby at a time. That's our preference. Ashanti, you are fine. You are fine, Ashantia. You are fine. I'm sure she did an excellent job with the surgery. And if you could get it done quickly, it's not a big deal. Just start making eggs, start making embryos, start saving those embryos. I do strongly recommend folks, if you're going to get surgery, get the embryos made first if you can. Lauren began bleeding after 6-week ultrasound, which has subsided now. Scared for the 8-week one now. Can I delay it until they can get to do abdominal instead of vaginal? Oh, you're thinking that the bleeding, you're associating the bleeding with the vaginal ultrasound. don't delay. You want to see what's going on with the fetus. We do see lots of bleeding in IVF patients. I mean, we really do. It's unfortunate, but true. We do see lots of bleeding, and they do fine. Can you talk about the DOR as in everything someone needs to know if they want to use their own eggs? I would look up my talks on low ovarian reserve, and then we'll get back to you. Is it possible to be pregnant while you're on your period today? I went in for my first baseline on cycle day 2, and my HCG came back 12, Maria. Well, could be possible when you're on your period. Yes, you could be pregnant and bleed. You call it a period, we call it bleeding. So absolutely, you can and stay pregnant even when you bleed. So definitely follow up with the pregnancy hormone in a couple of days. With DOR, if you only get a few eggs each retrieval or higher dose stimulants, would the mini protocol be appropriate? Absolutely, Amanda. Ugh, thank you. Who's ugh? Oh, thank you. I think ugh is a good thing, I hope. Okay. I'm not sure what you're saying. Do they ligate hydrosalpinx during laparoscopy? Yes, but you have to make sure you ask them to do that, please. Diminished ovarian reserve. I only have like 8 minutes left here. But all that means is that at your age, you have lower numbers of eggs predicted by AMH or by a previous IVF cycle than we expect. It just means you just have fewer, like you're less tall or you're less fast in a race. It does not mean you can't. It does not mean you can't find that egg, that embryo that's going to make a baby. Tori, is HCG 19 on HCG boosters a positive? I really don't know the answer to that, Tori, because it's confused. If the pattern goes up, then you are good. If the pattern goes up on the HCG, then you are great. Renee, I wish I would bank more embryos before we had an abdominal myomectomy. 43 now, I'm making less embryos. Should have got more embryos when I was making more. Right, that's a nice thing to say to folks. If you can, not everybody can, but if you can, make more embryos. If you can't, that's okay too. I mean, you're doing the best you can. That's the key here. Tommy, I'm going to use donor eggs and an FET. And Matt, do fresh eggs have a much greater rate of success to get blastocysts versus frozen eggs, or are they comparable? They're absolutely comparable today. In the past, that was not the case, but today they are comparable. All righty. Lauren's Journey to Be joined. A little bit late, Lauren. I only have about 2 minutes left. Truang joined a little bit late. Teach I Am a little bit late. Brittany Travel a little bit late. Sharmitha a little bit late. I start at 4 o'clock on Tuesdays, Mountain Time. That's 1 hour later than Pacific, 2 hours earlier than Atlantic, 1 hour earlier than Central. So guys, jump on at 4 and then we'll rock and roll. How's everybody out there? I'm Dr. Magarelli of CNY Fertility, Colorado. My goal every other week is to do a topic. Today we talked about the pearls of the Pacific, which was the Pacific Coast Reproductive Society. As a matter of fact, you guys, there's a lot more folks there. Let me do this. Let me quickly go through my pearls and then I'll call it a night. So pearl number 1, only you can see this, by the way, if you're on Facebook or YouTube. Pearl number 1, non-invasive PGTA, that's a no. It's not ready for prime time. Natural modified frozen embryo transfers, there's less hypertension, less preeclampsia in those patients who do the natural modified. However, natural modified also is dependent on timing, so you may have to rob Peter to pay Paul. Progesterone, PIO, pregnancy progesterone intramuscular, and vaginal progesterone together are improve live birth rates. Even progesterone and oil alone improves live birth rates. Vaginal progesterone alone does not improve live birth rates. And vaginal progesterone can't adjust well enough and quick enough with low progesterone. So you definitely want and ask for progesterone and oil. Vaginal progesterone only is associated with more miscarriages. All right. Oops, sorry. Let's go down. Why are you not going down? Oh, here we go. Mosaic embryos. We now know that 15% of all mosaic embryos are associated with, I'm sorry, all embryos are associated with about a 15% and to much higher level of mosaicism. The good news is mosaicism is not necessarily repeatable, meaning if you have it in one, it doesn't mean you have it in another. But the good news is that they're making babies, these mosaics, such that if you're greater than 42, if you put in the mosaics, you have 52% more embryos to transfer. And if you're less than 35, you have 33% more embryos to transfer. So definitely something to do. Endometrial receptivity assays, the ER-peak, does not improve reproductive outcomes as a first-line therapy. It may be helpful in those patients who fail, but it's not helpful to just put everybody on it. It's $1,000. Not necessarily a good use of your money right now. There's a new technology that's going to save and help our embryologists, which is called ultra-fast thawing, which will save us 14, 13 minutes, which doesn't sound like a lot, but when you do 20 or 30 of these a day, those minutes are tech time, and tech time is expensive. So it's a way for us to keep our costs down, but we're going to investigate it. Pregnancy rates, though, remarkably went up when we did the ultra-fast thaw. So, and as well as the implantation rates. So that is absolutely fantastic. In terms of what CNY does, we do recommend progesterone and oil injections plus vaginal progesterone. We do support modified natural cycles, although they are calendar related. We support the transfer of mosaic embryos. We provide the ERA. However, we do not recommend it for primary use, only if you have a failure and only if you have one euploid embryo. And currently, we do not offer non-invasive PGTA, and I don't think anyone right now should. So all you folks who just joined me on Instagram, which I don't understand because I'm just about to say goodbye. I'm sorry. I start at 4 p.m. Mountain Time on Tuesdays. Thank you, all you great folks in the Facebook land and YouTube land. Think Pregnant Thoughts. We're here to support you. If you have questions, definitely portal us. We do about 7 of these every week, or 8 of these every week. So thank you for joining me, and I look forward to seeing you guys next week. It's time for the kisses, everybody. Thank you. There they come. Thank you, guys. Bye.